So when we talk, I hope this is visible to everyone. Yeah. Okay. So when we talk about the lap cholecystectomy, this is the most common laparoscopic surgery that is performed. And do you know this is the surgery which is associated with maximum complication, even more than colorectal surgeries, even more than bariatric surgeries. So lap cholecystectomy, why this is a Pandora box? The answer to this is because of the unusual, unsuspected abnormal biliary anatomy. And the second thing is that not many patients are, you can say, always willing to opt for the surgery. So by the time they go for the surgery, they prepare themselves for the surgery. They might have had multiple bouts of acute cholecystitis, resulting in a lot of dense adhesions. And that is the reason why the chaos happens. So when we talk about do's and don't, the first thing that we have starts with the basics of ergonomics. Now, when we talk about ergonomics, it is all about the port positioning and the placement of, you can say, the monitor, the placement of, you can say, the ports, where the where the surgeon is to stand. Each and everything is important. So when we talk about this, I will share something with you. What are the most important things that we have to understand? There are three important rules in cholecystectomy or in any laparoscopic surgery. The first is the target. The first thing is you need to lock the target. This is the same way we suppose you hire a shooter, you hire a sniper to shoot someone. So first he has to lock the target, then only he can do anything. So this is the abdomen, and suppose this is the right costal margin, and here you have the target. So always remember the target, the camera, and the surgeon and the monitor, they are on the straight line. So this is going to be your monitor, this is going to be your target, and this is going to be the surgeon. That is why surgeon is standing here. This is very important. Now the next is, sir, where should we place the ports? Because I told you about the concept of ergonomics. Now try to understand, this is what is the concept of your port positioning. Now what is this port positioning? Let me tell you, this is very simple. Try to understand. Now whenever we have the target locked, so suppose this is the target, I will always put the two index at my target. So this is the target. The two thumbs will always be telling you about the, you can say, optical port, or where the main camera port is, and the two anatomical snuff box will be. So suppose if I place my index on the place where my two index are joining, they will be defining the what? The target side. The two anatomical snuff box will be defining the main working ports, and this thumb will be deciding the place where the two thumbs are joining. This will be defining the main camera port. This is the classical rule that all of you should be knowing. The next is, we all have studied physics, and many a times we often get confused. So I have told you that this anatomical snuff box, so these are your two index, and this is your thumb. So this is your thumb. So the place where the thumb meets will be your main camera port. This is an anatomical snuff box right, anatomical snuff box left. So wherever the anatomical snuff box you have, they will be pointing towards your classical, you can say, working port. So working port number one, working port number two, and this is going to be target. If you identify this, you will never have the first, you can say, critical problem. The next is, we all have studied physics. The most important thing is the concept of lever. So everyone knows that we have class 1, class 2, class 3 lever. Now class 1 lever is a lever where the effort arm and the load arm. So this is the load arm, this is the effort arm. This has to be, you can say, equal. So this is a class 1 lever, and we utilize this in our laparoscopic surgeries. Now dear students, try to understand, this is very important thing. Many a times if you go to your colleges, you always see that the surgeons are struggling, your professors are struggling. You see someone young doing the laparoscopic cholecystectomy, he knows that he has to dissect off the callots, but they don't know how to do that. Remember, imagine this is your port, and this is a working instrument. What will happen if majority of the working instrument is out and only tip is going inside? So this is a lever where the effort arm is big and load arm is small. So what will happen? A small effort will actually exacerbate or exaggerate your amplitude of force. And that is why you touch a tissue and you do a small manipulation and the bleeding starts, and you are thinking, okay, everything is fine, I don't know, this gallbladder is very fragile. No, this is not, because the ergonomics is wrong. Imagine if majority of the instrument is in and half of the only tip of the instrument is out. What is this? This is a class 3 lever. Again, now what is going to be a problem? You make a small move, nothing will happen. In order to make a move, you have to strain, and then when you are straining, there will be overshooting, undershooting, there will be pain over your shoulders, and this is the biggest problem. What is laparoscopic surgery is all about, or minimal access surgery is all about? It is not about you can say a specialized technique, a specialized field. It is about the safe dissection in a minimal access way. So this is what you need. So the next target you need to understand is, sir, half instrument should be in, half instrument should be out. And what is the standard size of the adult instruments that we use? So when we talk about the adult instruments, in adults, it is 36 centimeters. So 36 centimeter is the size of the adult instrument, and therefore minimum your port should be 18 centimeter. So whenever you have this, draw two arcs in the abdomen, draw two arcs. The first arc should be 18 centimeter away from the target. The second arc should be 24 centimeter. And whatever ports you are going to make, you are going to make the ports in this domain only. So now when you have this, you can always do that. So this is the target. In this port, you can place a camera port. You can place a camera port, and then you can place your working port number 1, working port number 2. Now the next task is, sir, where will I place my working ports? According to the baseball concept. Now, one student can say, sir, I can do my working ports like one port is this far away, one port is this far away. Now, try to understand. The ports are too far. When the ports are too far, your one hand is coming like this, your one hand is coming like this. Can you imagine the angle and the strain you are having at your shoulders? So, this angle between the two working ports, this is what is known as manipulation angle. So, the next thing that we have to understand is the concept of manipulation angle. Do you know 90% of the lectures, if you see on cholecystectomy, it simply starts with the posterior window safety dissection or with the Kellogg's dissection. No one is telling you about the basics. When you cannot enter properly, how will you do a surgery? So when you talk about the manipulation angle, what is manipulation angle all about? It is angle between two working ports. Now, when we talk about two working ports, this is the instrument. Suppose this is one instrument and this is another instrument. Now try to understand, if you can say, if this angle, this is manipulation angle. In order to have a good manipulation angle, what is the standard dimensions? Can anyone tell me? Let me tell you. But say when you're writing, the angle between the surface of your notebook and the pencil is 60. Try writing at 0 degree. Try writing at 90 degree. Just see the ergonomics is destroyed. So same is the case with laparoscopic surgery. So the ideal working angle, or you can say manipulation angle, is 60 degree. Imagine if you make the ports too close. So one port is going like this, one port is going like this. You can say your instrument will be what? Shouldering. And imagine the strain at your shoulders. Imagine they're too wide. Again, you cannot do. So this is what is the main crux, that the good manipulation angle of 30 degree to 60 degree. So when we talk about this manipulation angle, it has to be minimum 30 to 60 degree. This is what is the most important thing that all of us should be knowing. There is again one more thing, that there is azimuth angle. Now, what is this azimuth angle about? So the azimuth angle is angle between the telescope, the angle between the telescope and working ports. This is very important. Now, try to understand. Suppose this is the telescope port. So this is the telescope port. This is the working port number 1. This is the working port number 2. So this angle will be known as manipulation angle, and the angle between the telescope, this is known as AZ1 and this is known as AZ2. Remember, it should not be less than 15 degree and it should not be more than 75 to 90 degree. In robotics, we have it at 90 degree. This is But in laparoscopic surgery, we try to keep it less than 60, 65. Why? Because if you go far wide apart, there will be mirror imaging. So you will be doing something on the left, it will be going on the right, doing something on the right, it will be going on the left. So dear students, this is the first thing that we got, that okay, this monitor, target, everything has been settled. Next thing is we enter inside. Now the port positioning has been done. I have already told you about this slide. What is the importance of port positioning? Because it reduces the operative time. Imagine your monitor is looking is in this way. You must have seen in government medical college, people don't you can say they're not worried. So trolley is there next to the patient, and they're operating like this, looking like this. Imagine you are looking like this and operating for half an hour, you will have a severe strain. So this is very important. And remember, this is the most important, that whenever you make the ports, it should be such that you can do an at least 360 round diagnostics. Why? Because if you have any problem, you should be in a position that you can access at least all the quadrants. So let me tell you about the standard 4-port lap cholecystectomy. So what are the standard 4 ports that we have? This is the simplest thing that we can define. So you can understand, this is the main camera port. This is the camera port. Then we have the next is let me get it here. Okay. So the next is we have the working port number 1, and this is the epigastric port. Then right subcostal along the mid-clavicular line, this is the working port number 2, and this is the traction port. So why traction port? This is around the right anterior axillary line. So why this is there? This is to give the traction to the gallbladder. So I'll be showing you the videos where, so these are the standard 4-port. There are people who are doing it with 3 ports also. This is not something to be proud of. If you're comfortable, do the surgery in a comfortable way. So hardly 1 port is going to make a matter, but yes, it reduces the operative time and clutter also. There are a lot of places now where sills have been done, but what I personally feel, that single incision laparoscopic surgery sills, there is a sills port with the rotating instruments which can articulate basically, they are associated with higher risk of umbilical hernia because of a wider port, you can say umbilical port that is created. But the advantage is that they have the single port that you can think of. The next is the gas and the pressure. So I will come to this, but before that, let us talk about the classical concept of the access. So how are you going to access? This is one very important thing, that okay, sir, everything is ready. How should we access the, you can say, access the abdomen? And when we talk about access the abdomen, we insufflate the abdomen, and this is known as creation of pneumoperitoneum. This is very important. So how do you create that pneumoperitoneum is again a challenge. Now, what is the concept of pneumo? We are insufflating the gas. So what is the gas that we use? Try to understand. CO2 is the standard gas. Why CO2? The advantage is it is colorless, and then it is odorless, and then it is non-inflammable. This is the reason why you don't use oxygen. Now, again, there has been mistakes by surgeons who often tend to forget that many a times during surgery, the CO2 is finished. And when the CO2 is finished, they might do one big mistake of starting the, you can say, oxygen. And oxygen is inflammable. So when you infuse oxygen, what is the big problem that happens? It can cause, you can say, a blast. Intraoperative burns can happen. Some people forget about this, and instead of oxygen, they use nitrous, because nitrous oxide is also available. What is the problem with nitrous? It is again an excellent gas, excellent, colorless, odorless, and the advantage is it is also analgesic in nature. But why not nitrous? Because it is again inflammable. So the moment you use the diathermy, the moment you press on the cat, you can say on the pedal, there will be a burn. And this is again a chaos. So CO2 has to be used in case if you finish the CO2. Nowadays, you have that air, the natural air, room air can be used. So the new days insufflators, they have you can say emergency backup, that they will convert the intraoperative room, OT room air into this, you can say, standard insufflation mode. So there is a backup, that If you finish off the CO2, yes, you can use the standard room air for that, but not oxygen and not the classical nitrous oxide. Now, one drawback. Now, you must be thinking, sir, this is a class where you are explaining us each and everything, but you are not starting with the surgery. Do you know 90% of the problem happens because of these things? Recently, I did surgery on one patient. Post-operative patient was fine, but after 30 minutes, patient had a sudden cardiac arrest because of, you can say, maybe the post anesthesia apnea, and patient had a severe cardiac arrest. So these all things happen because if the planning was not done and the patient didn't tell us the history that patient had a previous apneic attack. So had this patient told us, we would have used something else or be more cautious. Now, one very important thing that I'm going to tell you, what is that? Try to understand. Try to understand. Whenever we talk about CO2, why I am discussing about CO2? This is important, very important. The CO2 is a gas which is having the sympathomimetic action. This is very, very important. So when we talk about the sympathomimetic action, what do we mean by the sympathomimetic action? The CO2, and this is a very famous question that is asked to, you can say, the residents or all medical students. So it causes sympathetic stimulation, and when it causes sympathetic stimulation, therefore there is tachycardia also, therefore, or there may be hypertension. So you need to avoid it in patients who already are hypertensive. That is why the moment you create the pneumoperitoneum, things will happen. Students, I will take the chat questions at the end. Because currently when I'm sharing the screen, it's very difficult to see the chat. So at the end, I will take all the chat questions. Let us understand more about things. Now, when we talk about the CO2 or when we talk about the pneumoperitoneum, so let us try to understand. Suppose this is the patient. Now, whenever you insufflate, so whenever the gas is going inside, there is increase in the pressure. Yes or no? So there will be stretching of the abdomen. And when there is stretching of the abdomen, there could be a possibility that yes, there can be vagal stimulation. So do you know that vagal stimulation can result in bradycardia, and this bradycardia can be a cause of cardiac arrest? So remember, when do you have this vagal stimulation or when in the risk? Whenever there is rapid creation of the pneumoperitoneum. If you see my videos, I usually take 1 to 2 minutes or maybe 3 minutes to insufflate. Why? Because slow and steady creation of pneumo helps me prevent this vasovagal collapse of the patient. This is very important. So now the question is, sir, what way are we going to use? This is very important. Now, the next is, sir, when we are talking about the, you can say, the creation of the pneumoperitoneum, we have two standard techniques. What are the two standard techniques? We have the Viris insufflation, which is considered to be the safest. So why Viris is, you can say, considered to be the safest? The reason behind that is the Viris has a slow flow rate, slow plus low flow rate. And when we talk about slow plus low flow rate, it is only 1 ml, 1 liter per minute. This is very important. Sometimes Viris might have 2 liters also, but 1 liter is the standard flow rate, and therefore there is slow and gradual creation of the pneumoperitoneum. The second very important thing that Viris has to offer is that if you look at the tip of the Viris, I'm sorry, my OT is closed right now. OT assistant might not be there. Otherwise, I could have got the instrument. I got a bit late. So the Viris, I'll show that in my videos also. If you talk about the Viris, the tip of the Viris is beveled. So the moment you go inside, the spring will go back and the pointed tip will come. The moment the Viris enter, again, the beveled end comes up. So inadvertent perforation of the viscous. So suppose I'm doing the, you can say, Viris axis, and I go inside and suddenly I collapse into a bowel or maybe a vessel. This causes catastrophic injury. And do you know the Viris is associated with only 0.06% risk? Now, there are a lot of people who say use safety trocar. I would always say use sharp trocars. And if you are worrying about this, instead of using sharp trocars, you can use optical trocars, but not the blunt or the safety trocars. The logic, the ideology that they have is that, okay, when we are using the blunt trocar, it will not damage. Try to understand, if you want to pierce this skin and if you have a sharp instrument, it will go like this quickly. But if you have a blunt instrument, it will take a lot more pressure. You will have to exert more pressure. And this means that suppose this is the abdominal wall. The abdominal wall has to be pushed more and it is more closer to the organs. And that is why a higher risk. So this is a myth that the safety trocar has low risk of perforation. Rather, it is more catastrophic. Is that clear? No. Yes, we can have, instead of that, you can use the Hassan's technique or the open technique. So this is nothing but a mini laparotomy. So you can do a dissection, open up, insert. That is okay. This is very, very, very important. Or the next is use of optical ports. Now, this is what I'm going to demonstrate also, how we go for an optical port access technique. One more important thing is, sir, what should be the standard pressure? 12 to 15 mmHg is the standard pressure. In case of kids, the pressure has to be 8 to 10 mmHg. For bariatric surgeries, yes, you have to have a pressure at least of 15 to 80 mmHg. Remember, pressure more than 20 mmHg increases the risk of CO2 embolism. This is very, very, very important. So CO2 embolism. Now you will say, okay, I'll play safe. I'll go for a low pressure. So whenever there is low pressure, the abdomen is not very, you can say, open up, and you will always, always, always have the risk of being very close to the organs and you will damage this. So what are the standard instruments we have? Laparoscope, graspers, scissors. Either you can talk about, when we talk about electrocautery, you can use monopolar, you can use bipolar, you can use, you can say what is my favorite, that is harmonics. Otherwise, you don't require. And yes, clip apply. There are a lot of clips that we have. So we shall be seeing all of them once we go and check. The next is, let us understand what is the Rouviere sulcus all about. So from here, I will show you something about the, you can say, the concept of laparoscopic surgery. So I will take you to one of my videos and I'll try to show this to you. So I hope my screen is visible. Just a minute. I'll open another window and I'll take you to the video section of this my app. So let us go to this residency section. And okay, so there are surgical videos. I'll take you to the access technique first. This is very important. So let me talk about this. Okay. So this is the video. So when we talk about this laparoscopic cholecystectomy, the first is, let me just expand it. I hope this is visible to everyone. Now here I am showing you something. And what is this? This is showing you the classical target. The C standing, the C here represents the camera port. So if I can write on this, yeah. So just see. Okay. So this is the camera port that I have. This is the target that I have. And these are the working ports that I have. This is very, very, very important. So this is working port number 1. This is working port number 2. And this is the traction port. So this is the classical, you can say, port positioning that we have in this patient. So just let me, okay. Let us move forward and let us see this surgery. Just a minute. Yeah. So let me play it for you. Now, this is a resident video. So a lot of residents come to my center and actually I teach them how to do this surgery. So let us quickly move forward. Now, talking about the varus, can you see this is all that we have? So this is a varus. And before that, I'm going for you can say umbilical Scandinavian technique. This is very, 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 very important. So what is that concept of infraumbilical Scandinavian technique? Below the umbilicus, I've made an incision. Now, this is the needle that you are seeing. This is a varus needle. And this varus needle is taken 90 degree to one port, 40 degree to another surface. Can you see this is the angle? And it is pointing towards the rectum. Now I'm doing irrigation because if it is gone into the abdomen, this saline will go. When I do an aspiration, nothing is coming except the air bubble. Why? Because it is the empty cavity. So nothing will happen. And this confirms that we have gone inside. Now the next is I will open up the pressure. Now can you see this varus insufflation is showing you 15 by 15. That means this is not, there was some occlusion. Now you can see the actual pressure. So if you see in this, the pressure is moving, fluctuating 2 8 2 8. That means there was some additions. Maybe because of that, maybe the momentum is coming. So this is the optical port I'm talking about. And this optical port is taken perpendicular. And can you see every layer? We can see what we are cutting. So now you can see we are going through the rectus. The red indicates the rectus. And very soon this will be negotiated. We'll have some fat. And now can you see, now it is yellow turning yellow. No, so we are going towards the posterior, you can say, part where the below the umbilicus, the posterior rectus ends. And you can see the yellow hue. Very soon you will see the transparent hue also. So we, now this is whitish, that is peritoneum. And now can you see this has gone inside. So we will open up the lock. We will take out this port. What is optical port? Optical port has a camera. Now you go inside and you see this is what is the gallbladder that you are seeing. The next very important thing that all of us, this is the classical rising sun sign that we have. The next important is, where is the Rouviere sulcus? Because without Rouviere sulcus, you will not be able to start with the surgery. So you can say we have made the ports. I'm not going into that. So let us quickly skip that part. Let us quickly skip that part and go. So you can see this is a case where you have the entire colon adhered, the bowel is adhered. So without jumping into any conclusion, I told you lap cholecystectomy is a surgery where you have lot of complications. So this is a residency case we have. So we have made the ports according to now confirming the anatomy. Let us quickly go inside and see how we can go forward. So I'll just come back. So the case which was appearing that, okay, it's very tough. Just see with the harmonic. So can you see with the harmonic, I'm just doing the, you can say, I'm just shaving off the structures. And very soon you will see that the gallbladder is in front of you. And everything is finished now. Almost for me, the surgery is finished in this case. Why? Because I have got the gallbladder in view. The next very important thing is, now you people or everyone will jump towards this. So let me tell you, I always look at one line, and this is what is known as R4U line. So what is R4U line? This line, let me pause it for you. Let me pause this video for you so that you can have a better, you can say, idea about the things. Just a minute. Okay, so what is this R4U line? I want to discuss something in this. Okay, just a minute. Dear students. Okay. I'm going to share you something. So let us go to this. And I am talking about the R4U line. Now, what is the significance of this R4U line? Understand this. Otherwise, you will never be able to do any dissection. So whenever we have the gallbladder, so we are often tempted to look at the gallbladder and start the dissection. Remember, there is a sulcus which is known as Rouviere sulcus. This is the segment 4. And here there is a fissure which is known as umbilical fissure. This line is known as R4U line. Now, what is the significance of this R4U line? Whatever dissections. So above this R4U line, above, or don't write above, you can say ventral to this, you have the cystic structures. And remember, dorsal to this, below this, you have the CBD and the hepatic structures. 90% of the injuries that happen during surgery is because people don't follow this concept of R4U line. So let us try to understand this concept of R4U line. This is the R4U line. Yeah, this is the R4U line that we have. Just see. So this is the Rouviere sulcus. This is the segment 4, and here you have the umbilical fissure. Remember, if you dare to go below this, many people are thinking that, okay, this is the calots. There are a lot of, I'll use a annotation. Okay, many people must be thinking that, okay, this is the place I'll open up the calots. Don't dare to start this. The moment you dare, you will end up damaging the what structures? Hepatic structures. This is very, very, very important. So let us resume this and let us start this. Okay. So just see. So I will start the dissection, and the next is opening up the posterior window. So we all have seen what is the R4U line, and now we will see What is the concept of posterior window of safety? Now, this is again very important. We are often thinking that, okay, for us, calots is the most important thing. No, students, the posterior window. So what is the posterior window of safety? Posterior window of safety for lap cholecystectomy. Remember, liver on, it is the under surface of the liver, point number one. The gallbladder and the cystic duct, and the common hepatic duct. So this is common hepatic duct, and this window is known as posterior window of safety. Now you must be thinking, sir, then where is calots? Remember calots, when we talk about the calots triangle is located inside cholecystohepatic triangle. And when we talk about cholecystohepatic triangle, what is the cholecystohepatic triangle? This triangle is known as cholecystohepatic triangle. And inside this, you have cystic artery, cystic duct. This triangle is known as Kellogg's triangle. I'll show you. Don't worry about this. So let us go to the app. So you can see these all videos are there on the SurgeryDada app and also on the Surgica Pro, which we are launching for the USMLE and the international residents, basically. So you can see I'm just doing the scoring of the mesentery of the gallbladder. So I have not started anything in the Kellogg's region. I'm not interested. The only thing that I am interested is to open up the posterior window of safety. Can you see? Just simply trying to make some space so that I separate my gallbladder. You must have seen, if you want to fight with someone without damaging others, so you will call that guy. You will say, okay, you come to us and don't disturb others. So again, so this is the same way. I don't want to mess with the gallbladder. I don't want to mess with the liver. I don't want to mess with the, you can say, hepatic structure. So let me pull my gallbladder away. And this is how I am starting with the cholecystohepatic triangle dissection. So I'll just increase the speed. Okay, just a minute. Okay, so I'll increase the speed. Now you can see I am opening what, students? So it's just a series of enteromedial, enterolateral dissection. And now you can see there is no posterior window of safety dissection. Posterior window has not been opened because there are a lot of adhesions in this domain. So just simply, I will try to do gentle maneuvers. And can you see now? Wow, the posterior window of safety has been opened. This is very important. So the posterior window of safety has been opened now. Now you will see where is cholecystohepatic triangle. Now you will see, sir, it is a pretty bleeding site. Why am I showing you this surgery? I'll show you surgeries where you will not even have 1 ml of blood. But this is a surgery where you have a lot of adhesions and you tend to make mistakes in these surgeries only. So where is the cystic lymph node? Now this is the cystic lymph node. Can you see? This is the cystic. This is the place where you will have the cystic lymph node. This is the cystic lymph node. Yeah, there is cystic lymph node in this place. So now, when I have opened up the posterior window of safety, now I am opening the calots. So you should be knowing there are a lot of things in this, So just see. Okay, I need a pointer. Let us just have forwarded by 10 seconds. Okay. So can you see there are two spaces detected here? So what are the spaces that we are seeing here? This is what is cholecystohepatic triangle. I'll make a bigger one. So this is entire one is cholecystohepatic triangle. And inside this, I'll use a separate color. This is a Kellogg's triangle. So there are two structures, cholecystohepatic triangle and Kellogg's triangle. This view, this is known as Lord Ganesha's view. This is very important. So, or elephant trunk view. I'll show that view also. Don't worry. So let us resume this. Okay. Okay, just see this. So now, once this has been done, it will not take a lot of time. Now, many a times, we might have seen some patients with Mirizzi syndrome. Now, what is the problem with Mirizzi syndrome? The duct is actually pulled up. Still, I am not interested into, you can say dissecting into clipping or doing anything. This is very simple thing. I have to understand the value that dissection should be clear. Now you will see I will clip up the cystic structures. So this is the cystic artery which I will be clipping. Whenever you are clipping, now this is a rule. I'll tell you, whenever you are clipping, one very important thing is, many a times it is a very common mistake that we all do, that, okay, suppose we want to clip this structure. This is the cystic artery, this is the cystic duct. We just get the clip applicator and clip it. Remember, when you want to clip, at least both the jaws should be visible, point number one. The second is the clip should be applied somewhere 1/3, or you can say 1/3 to the tip of the clip. So if this is the clip, you should not apply it here. The clip is not applied here. The clip is applied somewhere in between the, you can say, middle and the proximal 1/3. Why? This gives the maximum coverage. Otherwise, there's a chance that the clip might get overruled, you can say overlapped, or it might get, you can say, it might even slip off also. So this is very important. So just see how I will clip. In this video, I will show you the two types of clip applicators that we have. This is the standard titanium clip that we are using. So I have applied a clip. You can see both the jaws are visible. And once both the jaws are visible, press it a bit and then take it. My resident is applying. I'm not applying in this because I allow during the hands-on, I give a lot of hands-on to my students also. So once the clip has been applied, let us see. This is the cystic pedicle, and I will be dividing this cystic pedicle with the, you can say, with the harmonic. So you can see that without wasting any further time, I'll divide it. There are still dissection, there are still, you can say, some adhesions. So before dividing, you should be quite assured that you have not taken any other structure. So you can see this is the calots. This is the cholecystohepatic triangle, the bigger one. And inside this, we have the calots. And this is the Lord Ganesha's view, or the elephant trunk view. This is the Lord Ganesha's. Now you can see we have got one hemlock clip. Now what is the difference between this hemlock clip and the another one? The whitish clip that you are seeing has a lock. So if you see this clip once applied will get locked. In a conventional clip, if you talk about a conventional clip is something like this. But hemlock has a lock, and the moment you apply, it will get fixed. So this is a, you can say, polymer of you can say PTFE polymer, and this is not a metal clip. It has lock and it is barbed, so it will not slip, unlike the conventional clip. Now you'll say, then why everyone is not using? The answer is because it is very costly. So the cost of one hemlock will cover 3 sets of maybe the Liga clips also. So I'm dividing with the harmonics. You can see even if you use plain harmonic on the cystic duct, it's not a problem. So I've given chance to one of my resident to do this. That is why. So this is a residency video. Now you can see a big, you can see, just a minute. There's some problem with the video. Okay. Now you can see a big duct and the gallbladder and the CBD. So this is the place where you have, so this is a classical elephant trunk view. Can you see this elephant trunk view? So just imagine this to be the elephant trunk, this big elephant trunk. And we have got ideal window. Now, why do you think that I have done so much of dissection before surgery? Now, let me tell you one very important thing is that many a times, this is the gallbladder, this is the short cystic duct, and along with that, this is the CBD which has come up. And many a times you create this window and you put a clip and divide it. The moment you put a clip, you divide it. Now you land in a no man's land. Why? Because this is the division that you have, but the gallbladder is still adhered. Now you need to do one more injury. It is said that if you have damaged CBD, you need to do more injuries to get the gallbladder out. So now you will have to cut CBD here also and then do an edge. So remember, that is the reason why always and always create a big posterior window of safety. If you see in this video also, I've created a big posterior window of safety. There's a dictum, big surgeons create big windows, make big windows. Still I have not clipped CBD. Now you can see that if it had been CBD, going like this, it would have entered into the liver, but it has not. It has gone directly into the gallbladder, confirming. Now, this is what is the hemlock I was talking about. Just see, the hemlock is having what? The lock. So it is having the jaw, and now you will see I'm demonstrating my residents how to use this. Can you see? We have to grasp it, take it to the side, apply it. And once this is done, you can see I have asked my resident to apply. This is again one more clip that we have put, and you can just simply divide this. So once this is divided, the surgery is almost finished. So you can see each and every structure has been beautifully delineated. Dear students, I'll show you one more, you can say, good case before we just conclude this. So let me tell you something before we move. So what are the variations? Why are we scared? We are scared because of just one thing. And what is that, students? That is the aberrant structures. So this is very important to avoid injury to the hepatic ducts. If required, intraoperative cholangiography. I've told you that yes, we can have injury to the CBD. I've told how we can have. So this is very important that we adhere to the standard techniques, the proper anatomical steps. Now try to understand. I'll share one more good video with you. And sometimes when we have a wide cystic duct, in that case, we might have to require what, students? We might have to require a suturing, not closure. So I'll show you. Just see, this is a Mirizzi syndrome case. So Mirizzi syndrome is again a very interesting case that we have. So just try to understand. Again, I'll go quickly inside so that you don't miss out a lot of things. So this is classically dangerous gallbladder. Try to understand, everything is caked here, and still you are not having any view. Proper view is not there. The biliary anatomy is also altered. Just see, so much high. The Rouviere sulcus is still not visible in this case. So these are the cases where the chaos happens. Just see, the gallbladder is totally frozen and adhere to the, you can say, the anterior abdominal wall. There is no space with the liver also. Can you see? This shows that it is a case of empyema with Mirizzi syndrome, and a lot of chaos is there. So these cases are very challenging, and they can, you can say, damage your reputation. Just see, there is so much of pus coming out. So I'm showing you all the, you can say, bad cases so that you can understand. Still the Rouviere sulcus is not visible. So I am in these cases, dear students, you should be using the blunt instruments. So I am using the simple suction. So I'm using the saline irrigation dissection technique. And with this, very slowly, there is no one known as fast surgeons. Anesthetists will say, okay, you have done it in 30 minutes, 20 minutes, you are the great surgeon. He is going to praise you because he wants to go get free and go to another case. But what will happen if your case goes wrong? He's the one who will cry out everywhere that, oh my God, Dr. Dixit has done this, your fellow surgeon has done this. So you can see, still we are not having any clue. We are not having clue. So in this case, whenever you have a Mirizzi, do a partial cholecystectomy. Can you see I've opened up the gallbladder? I'm not bothered where is the callots. I have opened up the gallbladder. And once you open up the gallbladder, the next thing is where the stones. So you need to milk out the stone. And can you see I'm milking out the stone? The stone is very soon going to be visible in front of you. There's a lot of purulent tissue, and this is adhered to the duodenum also. So the stone will be delivered out. So you can see the stone has been, I have taken out the stone. I'm showing you because Mirizzi syndrome is the most dangerous thing that you can have in your career. So I've dropped that stone. We'll collect it later. Now the next is there will be more stones. Now the next is I will use the knot, because here you cannot put a clip. So for that case, we are going to do an intracorporeal, extracorporeal knotting. So I am doing the SD's knot or SurgeryDada's knot. So just see, I'm taking the suture inside. The suture has gone. I have created the window behind the, you can say, behind the gallbladder. Just see, I've created window behind the gallbladder. And since I've created it behind, I know I'm not damaging any hepatic structure. The next is I will take this suture out. But before taking this suture out, you need to feed the extra length of sutures inside. So just see, I have put a lot of suture. Now I will take this suture out. Now when it is out, the next step is to tie a knot. So this is a SurgeryDada's knot or SD's knot where I've taken two hitches. Can you see I've taken two hitches? Next is I will take two winds. So this is configuration of 2 and 2 now. Now the last step is I will do a 2 locks also. So 2 winds, 2 hitches and 2 locks. And that is why this knot is 2, 2, 2. You can also say a modified Rodder's knot or anyone, but I call it SD's knot because I am the one who uses this. Apart from me, now my students are using. So you can see I have created a knot. Now, once this knot has been, since it is a suture, it tends to slip. So let me just, okay. So the knot has been created now. Now you will see I will try to slide this knot and this knot is going. Now why my assistant has put a finger so that we don't lose the pneumoperitoneum. So now one more click is, if you see there are two, three, now this is a knot pusher. This is a knot pusher and there is an eye in this. So we fix the suture in this and we put a reducer. So this is a 10 mm to 5 mm, 5 mm to 3 mm. So this is a 3 mm reducer which has gone inside. And now you will see why this reducer, so that we don't lose the air pressure. Now the knot will comfortably be glided to the side. Just see. So we have gone to the side where we wanted to place the knot, and now you see I'm going to tie the knot. And once the knot has gone, I've gone way below. Just see. Very soon you will see the knot is being tied taut. Do you know I don't need even a second suture? Can you see there is a dumbbell formation which has come? So this is what is subtotal or partial cholecystectomy. So I have not dissected, I have not tied cystic artery, cystic duct separately. I have just divided it. Now just see, with the help of a harmonic scalpel, with the help of a harmonic, I will divide. I'll also put one more knot, I think, in this case. So once we have got this, I will remove, there is one more knot. I'm just quickly moving up. So I put one more knot here. So we have placed two knots to be double assured of this. So same way with the help of a knot pusher. Again, same way, we are going to go inside, push the knot. And now with a harmonic, can you see the gallbladder is so bad? It is so bad, ugly looking gallbladder. Everywhere you are touching, it's actually, you can say, filthy, fragile, and these are the gallbladder which will destroy your career, because everyone will say, okay, you went for a gallbladder surgery and the doctor killed you, or you died, or the patient died, that doctor deserves a, you can say, a treatment under macoca and this and that, blah and blah. So this is the very simple thing. Whenever you get a difficult frozen callots, do a partial cholecystectomy rather than damaging the CBD. There is no problem. I've opened up the gallbladder, evacuated the things, and just see that ugly looking gallbladder will also be very neat and clean. Now I'll use a endo bag. Now in this case, I will suture the stump also, because I think that was too wide. So you can see I will take, this is a combination of intracorporeal as well as extracorporeal. Why I'm not showing you that easy gallbladder? Because we are a high risk center. So we perform all high risk surgeries. So these are the surgeries which require an utter precision. So if you see, we have done extracorporeal suturing also, and now we are doing a closure of the stump. And this is how the patients of Mirizzi's need to be mentioned, to be treated. Otherwise, students, you will not be able. Now, there are a lot of people who say that whenever you find a difficult gallbladder, go for an open. Remember, something which is difficult in laparoscopic cholecystectomy, in lap, is more difficult in open. Why? Because in open, you see a very small vision. The only thing is that you are not trained enough, you're not confident enough, and that is why you keep on, you can say, flickering your brain. So you can see, not only we have done suturing, we have put a knot. Now we are doing intracorporeal closure of the stump. So just see, now I will go for a surgeon's knot. So once we have done this, let us see how we make a surgeon's knot. Just see, two winds, the same way you do in open surgery. So to one roll, two roll. So you do the same in the, you can say, open surgery also. You rotate your suture needle holder twice around the suture. Just see, I have done the same thing. So I've taken the bite and now I will tighten it. So this is intracorporeal. Why I have not only taken intracorporeal? Because intracorporeal is almost weak. And this is very important. If you notice one thing, I'm not handling the needle, because if I touch the needle, there's a chance that I can perforate the organ, nearby organ. So you can see the duodenum. Can you see the abnormal pulsation of the aorta here? So that is why the viscera is coming up. So there may be a case of pseudoaneurysm or something like that. I don't know why this is happening, but yes, it is there. So this is a patient with recurrent, you can say, gallstone pancreatitis with Mirizzi syndrome. That is why. Now the surgery is done. The stump has been closed. And simply I've taken one more bite here. So you can see the surgery is complete. Now I'm removing the gallbladder. and the surgery is done. The patient discharged, bill paid, everything fine, and he gave a good Google review. And now, Babu Bhaiya, paisa hi paisa, paisa hi paisa. This is one. So surgery is not about making money. It is about the satisfaction. One more case, dear students, I will show you one more case. So let me just show you a congenital anomaly. So this is a Phygrian cap defect. So let me show you a case of Phygrian cap. You must have seen the anomalous gallbladder. So, okay, we have the chat feature on the app also. You can chat with our executives. Anyway, so we'll go inside same way in from Lycal technique. This is the VRES that we have, and it is pointed and taken inside without wasting further time. It is let us go inside. So this is again an optical port entry. I'll show you how we go for an optical port. The advantage is that you put a camera inside the telescope inside the camera and you move inside. So very soon you will see we are negotiating going down layer by layer, and now you can see the clear view. So once you see the clear view, that indicates that yes, we have gone inside. Now let us see. This time again we will have a different view. So I told you now, this is a Pandora box where we get a lot of surprises. So just see, let us make the port. I'll go inside. Okay. My residents have made the port and I allow them, because if I don't allow them to learn, so how will they? Now just see, this is the gallbladder in this case. We have seen variety of cases. Just see this. Okay. So in this, the gallbladder is totally having a different type of, you can say, anatomy. Let us go. This is a 70, this patient is 82-year-old. Now, this is again having a different anatomy. You can see the Rouviere sulcus is also a very different type of Rouviere sulcus. So I'm showing my residents how to, you can say, maneuver and check the things. So where is Rouviere sulcus? Rouviere sulcus is here. This is the Rouviere sulcus that we have. So I'll show it again. So this is the Rouviere sulcus. This is the R4U line. Can you see I am staying above the R4U line? But again, there is abnormal anatomy. So very soon you should see that thing. So what is the next task? To open up the posterior window of safety. You will see that there's a duck-shaped gallbladder. Very soon you will see that this gallbladder is having a very abnormal shape. So just try to understand this. Very simple, very simple. So let us move forward. Okay. Okay. So in this, you are seeing we don't have a proper anatomy, but just see. We are creating the posterior window. Stay with the rules that, okay, I have to stay above the Rouviere sulcus. We have created the posterior window of safety. And now you can see the structure. So this triangle is Kellogg's triangle. Above is the cholecysto. The bigger one is cholecystohepatic triangle. And this is the Kellogg's triangle that you have. So very important is you can see there are two vessels. There are two vessels and we are clipping the vessel and we will divide. Just see the meticulous dissection. It is not bleeding. You are having a 25 times magnified view, and the upper pole I'm taking just with the what? With the harmonic. I'm not even putting a clip on that. So we will divide it. So once we have divided it, now you can see a wide cystic area. So cholecystohepatic triangle is widened, and then the very same thing that we have is, let us clip on the cystic duct. So this is a hemolog. The white color polymer clip is a hemolog. What is the advantage? No cat-eye stone formation. Can you see it gets closed? There's a jaw. So you can see the jaw and you can always press it. But once it is pressed, dear students, it will not come out. And that is the reason when you're putting the hemolog, you should be double sure, triple sure about the structure. So you can see the gallbladder has been separated. And with this, you can say, I will, just a minute. Okay. Stop sharing. So with this, I have shown you a lot of variety of cases. Now I will take the queries. Anyone who wants to ask any question, has any, you can say, doubt, you can ask me. I hope, dear students, you enjoyed this session. Are you able to get anything or no? Was it just a...
Thank you for this informative session and amazing surgeries. It's very interesting to watch all these surgeries. So
And,
we'll
and there are a
allow.
lot of videos. There are a lot of videos which are available on my app, SurgeryDada. Let me tell you something about SurgeryDada. SurgeryDada is not a platform. It's an emotion. It's a must-have thing where we nurture you from developing that insight that, okay, I want to be a surgeon, then we train you to become an insane level surgeon, so that so we not only teach students, we actually upskill you guys to become a surgeon. So do check out the app also, SurgeryDada, and we are also launching Surgica Pro for the international students. Yes, yes. Now.
Yes, so there are questions in the chat box.
Yeah. Is it normal to have symptoms of cholelithiasis after 5 months of gallbladder removal? Uh, do you know, like Modak Disha has asked this question. Basically, it is not the symptoms of cholecystitis. It is basically the gallbladder dyspepsia. So when you remove the gallbladder, the enterohepatic circulation takes minimum 6 weeks to maybe 6 months. And that is why many times you can have these symptoms. This is very, very, very common. And thank you for everyone who is appreciating my, you can say, efforts. I'm a very low profile faculty, but a faculty with a lot of swag, because I believe that students need the best of the content. There are a lot of people, there are a lot of apps who are teaching surgery, but they actually don't teach surgery. Okay, Mohammed Taki has asked a question, sir, what is intracorporeal and extracorporeal? What is a Rhodes knot? Remember, if you see in the surgery, I have created the knot outside and applied it in. So that is what is known as extracorporeal. That means the knot created outside the body taken in. That is what. Remember, yeah. And if the knot is taken, if knot is you can say made inside. So if you see the suture that I used, you can say I made a surgeon's knot that was intracorporeal. So if you actually make a knot inside the body, that is what is known as the intracorporeal. And if you make the knot outside the body, it is known as extracorporeal. This is very important. So someone wants the link of the website. It is surgerydada.classics.co.in. So even the host will share you the link of the, you can say, my website or my app also, so that do share it to them so that they have the maximum benefit. There are a lot of free videos, lot of things. Okay, so Senti has asked a question. Dr. Senti has asked a question. Just a minute, I am not able to see. Okay. Just a minute. Where is the video? In the video section. In the video section. Okay. Sentence: how to differentiate between the cholecystohepatic triangle and the Kellogg's triangle in case of right hepatic artery hum? Remember, this is a very good question. I didn't have that much of time because I have uploaded one case of caterpillar hump. So if you give me 1 minute, I can do a screen share, and I can, if it's possible. I hope I can. Do we have time for that? Do we have time?
Yes, sir, sure.
Just give me a minute. Just give me a minute. Okay. I'll share one video. So whenever we talk about the caterpillar hump, this is the most dangerous thing that you can encounter during the surgery. Just give me a minute. I will just share with you the caterpillar hump. I have recently shared a video on this, so that will help you understand. Okay, so I'll share my screen with you guys. Is this visible? Just try to understand. This is the very same thing that we are looking at. But if you see in this video, there is something abnormal. I can see the flickering where my harmonic jaw is there. Your eyes will not see what your brain doesn't know. So many a times people will think, okay, I've created a posterior window of safety. Let me dissect and open up. But what helped? I sensed that something is broad here, something is flickering here. Usually we don't get to see a cystic artery going that much wide here. Now you can see the artery is going. Now it is looking like that, yes, it's a posterior, you can say, branch of you can say, cystic. But still, I have a doubt, because you can see a cystic lymph node, which is going way ahead. And this is a structure, which is a structure of doubt. So again, I will take some more time and I will have some more dissection. So it is a typical Lord Ganesha's view, everything is okay. But here we are getting two vessels. Can you see two vessels? So whenever you have two vessels and the posterior vessel is looking broad, always think that it's a Moyni-Hens hump. So you will be surprised to see that in this case, we have a very short cystic artery. Very soon, you just see I'm demonstrating each and everything. It feels like, okay, everything is okay. Everything is fine. Let me go and clip it. But just see now. Oh my God, this is a so wide thickened vessel. Can you see? This is a wide thickened vessel and it is having pulsations also. Just see. So this is what is the beauty of dissection. Not even one drop of blood here and there. I have just bared of the entire right hepatic artery. So this is a right hepatic artery. Can you see the pulsation? The moment you leave that, it is pulsating badly. So the moment you leave, it is pulsating. And now you will see the caterpillar's hump. This is what is known as a caterpillar's hump or a Moyni-Hens hump, where you have aberrant looking right, you can say aberrant right cystic artery, right hepatic artery, which is quite tortuous, going in that plane of cholecystohepatic triangle. And that is the time when you actually mistake and divide it. And then many a times the clips might slip or you might damage it and the bleeding will start. So you will see, I will divide my cystic. This is very simple. Just see, I will divide it. I will divide it and you will have a better view. So this is what is a classical Moyni-Hens hump. So I hope, just let me stop here. Yeah. So I hope Dr. Senti, you got your answer, and everyone can just enjoy the lectures. That those lectures are, you can say, present here. Okay. So this video is on my app also. Some part of this video is there on the YouTube. Everyone can go to SurgeryDada app. So it's an app available on on iOS Play Store. And for international students, currently you can use the web version. We can go to surgerydada.classics.co.in. I'll share it, and you can also join me on the Telegram for any, you can say, query you have. So I hope that's fine for the day. Anyone, any query, you can just unmute your mic also and ask the queries, not only in the chat box. You guys have so lovely face. So why aren't you turning on your camera so it makes the class look more lively?
Anyone who wants to say anything can please react or like give me a thumbs up, then I can unmute you.
And thank you for all the patience that you have shown to my video, my lecture, or my whatever you say, the presentation. But I tried my level best to get you what actually the surgery is. Surgery is not about mugging up like mnemonics that everyone is going into. Everyone has entered into a rat race where your seniors tell follow this app and mug up, mug up, mug up. Why I left all the apps and why I started my own app? Because I am a surgeon by heart, by, you can say, by hands. So I want the generation to learn. Remember, if you mug up a subject and when you go and present yourself in front of a patient, you lose that patient, you lose that, you can say, charisma that you have. If you see my personality, I have a lot of confidence because I know what the things are. You can get a degree, you can pass MCQ based exam, you will also get a degree, no one will stop you. But what after that? You need to have that spark, okay, that I know the subjects. And that is why you can delay your selection by 1 or 2 years. But whenever you get selected, you should be a confident doctor. You should be asking yourself, am I fit enough to treat the patient or no? So how to understand what we are seeing on monitor? Despite you explaining, I still find it difficult to understand camera orientation and what structures. Surgery is time taking. I've done more than 20,000 surgeries. So if you see a mom and a kid, so the kid is not newborn doesn't know how to speak, but mom will understand, okay, he wants milk, he wants to change, he wants something, like he wants to change his he wants his diaper to be changed, he wants this, he's feeling that. So that is how the surgeon is. So when we have done a lot of, you can say, work on the patients, we see the tissue and know what is behind that. We know what is in the heart of the viscera, what is inside that viscera, or what can be. But still, you will always have a scope of learning. Everyone is learning every day. Everyone. We all are, you can say, learners. And throughout our life, Because if you become that, you can say that confident and say ki, okay, I have learned everything, that means you have not learned. And the day you stop facing the problems, complications, that means you have not got the, you can say, taste of surgery. Complications are inevitable, and if you get complicated cases, try them with a challenge. Go slow, go well. Today I could have, you can say, yeah, Raghav, you want to ask a question? Yes, Raghav, you can ask a question. You can, there is nothing known as a fast surgeon. A surgeon can be good or bad. Yeah, Raghav. You can unmute. Host, you can
Yes,
unmute.
sir.
Yeah.
Hello, good evening, sir.
Good evening, Raghav. Hi, how are you?
Thank you, sir. Sir, so this is more like a feedback, and sir,
Okay.
I like enjoyed this session so much, and sir, it was so informative that, sir, even after watching like hours and hours of videos on YouTube, I couldn't get hold of concept of like baseball diamond concept, and I watched your videos multiple times,
Yeah.
and sir, it was only today that I clearly, got hold of like what diamond baseball concept is. And sir, in this hour, like sir, the basics of laparoscopy like were so clear and crisp. Like even after spending, sir, hours and hours on YouTube, like I wasn't clear, and now today I'm glad like I was clear on the basics of laparoscopic finally. Even after watching like advanced videos on laparoscopy, so today I got hold of like basics, and sir, that was an amazing session, like spot on.
I have decided that whatever life I have left now, I'll dedicate it for my students, because my professor, Professor Abhimanyu Basu sir, he has said, just he told me one thing when I was leaving the college. He said, lot of people want to earn from the society, try to give something to the society. So I want that if I make some contribution in bettering or in upskilling you guys, even after me, my name will be there. You will always say that, okay, this is SD's technique, this is SD's not, this is the way SD did it. So that is what I want in my life. I want to make an impact in the heart of my juniors. I want to treat them, because today no one wants to teach you guys, because everyone believes that, okay, there's cutthroat competition. If I teach them, they'll my competitor. Nothing. I'm not immortal. I will also, you can say, be a patient, and you will be the doctor. And imagine if you guys are not trained enough, you will be experimenting on me, thinking my gallbladder to be spleen, spleen to be kidney. So that is what I want. So, and one more request to everyone: whenever you guys have time, do come to my center to learn laparoscopic surgery. So we have a lot of courses for you. Not only we teach, we train, we upskill, we network, we do everything. So surgery that is a complete universe. Do check out SurgeryDada. It will help you. And do tell your friends, because you people are the only, you can say, publicity tool. I don't advertise. You guys are the only one who will always recommend SurgeryDada everywhere. And that is how the chain, and we will become better surgeons, better oriented doctors. That is what.
Yes, sir. Thank you so much, sir. Like as much as we want you around forever, and sir, there there are not a lot of like mentors who are ready to like mentor us, and like sir, the spontaneity of your sir, the mentorship, sir, is like sir really applaudable, and sir, I really enjoyed the session today, and it was very
Thank
informative, like truly informative.
No, thank you so much. Thank you. And Mohammed Taki is asking, do you have a center in Bangalore? So this is a future aspect, that we will be starting two more hospitals, one in Dubai already in the process, and one in Bangalore and Hyderabad maybe. So we're into the process. Maybe if the luck permits, if the money permits, so we might be coming up with the future projects, and then you can also join us. So my lovely students, I hope you guys enjoyed, and we will meet again. It's just an initiative. We have just started, and we will meet again and again until we actually all are upskilled. So let us pledge that we all have to be upskilled. So signing off the meeting. I hope you enjoyed. Any further questions? I hope you can also text me. You can take my